Hi, everybody. I'm Sheila. I'm a lead laboratory genetic counselor at Cooper Genomics, and I'm excited to be with you today. I want to begin with how our session will be laid out today. We're going to start with a brief overview of mosaicism. I expect that this is going to be a review for most of you. We're going to talk a little bit about how mosaicism is reported here at Cooper Genomics. We're going to touch on the guidelines that are available to help prioritize embryos for transfer that have Mosaic PGTA results. And then my colleague Jennifer Garbarini is going to talk to you a little bit about the different chromosomal disorders that can potentially result in a live birth, speak a little bit about the clinical impact of transferring embryos that have Mosaic findings for these chromosomes, and talk about how we approach genetic counseling for these results here at Cooper Genomics. As a reminder, PGTA evaluations at Cooper Genomics are completed on our PGTAI 2.0 platform. Utilizing our next generation sequencing technology, in addition to paired end sequencing, this platform allows the identification of all forms of triploidy, including female triploidy, commonly referred to as 69XXX. Identifying this condition using previous platforms was not possible. In addition to now being able to identify all forms of triploidy, PGTAI 2.0 also offers the option of parent of origin testing, as well as 2PN validation. So let's start with a quick overview of mosaicism. Mosaicism is a well-described phenomenon in all areas of genetics. Pre-implantation genetic testing is not an exception to this. As it applies to pre-implantation genetic testing for aneuploidy, mosaicism is generally defined as the presence of two or more populations of cells with different genetic compositions identified in one embryo sample. When a biopsied sample is obtained, it is hoped that the result from that sample will be representative of the entire embryo. However, we know that is not always the case. In a scenario when there is a Mosaic PGTA result, it is possible that that mosaicism is confined only to the trophectoderm, and the inner cell mass of that embryo is in fact euploid. It's also possible that the inner cell mass could be entirely aneuploid and the trophectoderm has mosaicism. And finally, it's possible that the identified mosaicism is present throughout the entire embryo. Whatever the case may be, we know that identifying embryos that have Mosaic PGTA results may better prioritize transfer decisions, as we know that Mosaic embryos have a lower rate of implantation when compared to their euploid counterparts. If a pregnancy does result, we know that the risk for miscarriage is higher. And as our patients never fail to point out, we also know that some transfer of Mosaic embryos will result in an ongoing pregnancy and a live birth. Mosaicism is a phenomenon that is seen across all age groups. It's important to remember that the chance of identifying a Mosaic embryo sample is really independent of maternal age. If you look at the data that's presented here, which was collected internally at Cooper Genomics, you will see that the chance of identifying an embryo sample with a Mosaic PGTA result stays relatively consistent through about age 40. Now, after age 40, the chance of identifying a Mosaic embryo sample at the time of testing does appear to go down, but that's not because the risk of mosaicism changes, but rather it's because as women get older, they are more likely to have a concomitant full aneuploidy identified in the same sample that also has a Mosaic finding. How do we report mosaicism information at Cooper Genomics? Our PGTAI platform has improved our ability to identify mosaicism in embryo samples. When this platform was being developed, a series of titration experiments were conducted. These experiments began with a normal or euploid DNA sample, illustrated here in green. And Abnormal DNA was titrated in increments of 15%. This titration allowed the artificial intelligence, or AI, to learn and to be able to identify normal DNA samples from abnormal DNA samples. This was repeated over 270 samples to ensure accuracy. This technology has the ability to identify mosaicism at a resolution of about 10%. Although we have the technical ability to identify mosaicism at a resolution of about 10%, in accordance with current society guidelines, we do not begin reporting mosaic findings until they are identified at a resolution of 20% or higher. When PGTA results are reported, these are the current mosaic reporting thresholds that are being utilized at Cooper Genomics. If a mosaic finding is identified in less than 20% of the cells tested, that sample is resulted as euploid. This is in keeping with current society guidelines. If a mosaic finding is present in 20 to 40% of the cells tested, that sample is resulted as a low-level mosaic. If a mosaic finding is identified in more than 40 and in up to 80% of the cells tested, that sample is resulted as a high-level mosaic. And if a finding is identified in more than 80% of the cells tested, that sample is reported as aneuploid, again in keeping with current guidelines. One thing to note is that some embryo samples will have more than one mosaic finding. When this happens, the overall score assigned to that sample, meaning whether it's identified to be a high-level mosaic or a low-level mosaic, will correspond to the highest mosaicism score identified. So as an example, if an embryo sample has a mosaic finding for trisomy 1 and it's a low-level finding, and in that same sample, trisomy of chromosome 3 is identified and it's determined to be a high-level mosaic, that embryo will go out as a high-level mosaic embryo. Most of us have worked with patients who have received mosaic PGTA results. In some cases, these patients may be considering transferring one or more of their mosaic embryos. There are society guidelines that have been published to help prioritize these mosaic embryos for transfer, and I want to review those now. I specifically want to touch on the position statement put out by PGDIS in 2016 that was updated in 2019, as well as the position statement put out by CoGen in 2017. For those who may not be familiar with these published guidelines, they have a lot of similarities, which we will touch on here first. However, there are some differences, which I will highlight in the next slide. Beginning with what these guidelines share in common, both societies recommend the transfer of embryos with euploid PGTA results whenever possible over the transfer of an embryo with a mosaic PGTA result. If an embryo with a mosaic PGTA result is being considered for transfer, both societies recommend embryos that have a single mosaic finding. Not surprisingly, both societies also recommend transferring embryos with low-level mosaic results over high-level mosaic results. And both societies categorize any chromosome finding that's associated with a known syndrome or a risk for UPD as the lowest priority for transfer. Where these guidelines begin to differ is in the chromosomes each society considers to have a risk for an impactful outcome. In this schematic are CoGen's recommendations for how to prioritize embryos for transfer that have mosaic PGTA results. Now, of course, embryos that have a euploid PGTA result should always be considered for transfer over any embryo that has a mosaic finding. However, in cases where that is not feasible, each chromosome has been listed here in order of priority, with that first category right underneath euploid being the chromosomes that appear to have the lowest risk for an adverse outcome when they are identified. And that would include chromosomes 1, 3, 4, 5, 6, 8, 9, 10, 11, 12, 17, 19, and 20. After embryos that have mosaic results for these chromosomes, embryos that have mosaic findings involving trisomies 2, 7, or 16 might be considered. These trisomies are of lower priority because trisomies of these 3 chromosomes have been associated with an increased risk for intrauterine growth restriction. So there is a concern for potential pregnancy complications. If those are not available, embryos that have PGTA results that have mosaic findings for trisomy 14 or trisomy 15 might be considered. These are of lower priority because they are associated with an increased risk of something called uniparental disomy. My colleague Jennifer will be talking about this in more detail in just a few moments. And those chromosomes with the lowest priority for transfer include trisomies 13, 18, 21, and 22. All of these have been associated with a risk for a live-born child with a disorder related to this chromosome finding. Now, when you compare COGEN's guidelines to PGDIS guidelines, one difference that you will find is that PGDIS guidelines list chromosome number 22 in that first category, so as having the highest priority for transfer when thinking about transferring a mosaic embryo result. And what I will say here is that trisomy 22, while very rare, has been reported both as a full aneuploidy in live birth and has been reported with long-term survival in a mosaic form. And so while the overall risk of an ongoing pregnancy and live birth impacted by trisomy 22 is smaller than the risk for trisomies 18, 13, or 21, it is a real risk. And I suspect that might be the reason for the difference between the two societies and their recommendations. In addition, PGDIS guidelines list the sex chromosomes X and Y as being the highest priority for transfer. So they're in that first category. COGEN recommendations don't talk about sex chromosome aneuploidy or mosaicism really at all. I would also like to point out that neither set of guidelines addresses the possibility of transferring embryos that have segmental findings. So an embryo that has a deletion of a portion of a chromosome, or an embryo that has a duplication of a portion but not the entire chromosome. Neither set of guidelines addresses how those embryos might fit into this prioritization schematic. Thank you all for your attention. At this point, I am going to turn it over to my colleague, Jennifer Garbarini, to talk to you a little bit about this last category, these chromosomes that we know are involved in a risk of live birth, as well as the chromosomes in the second to last category, the ones that we know can be associated with uniparental disomy. Thank you so much for your attention.
Thank you, Sheila. So I'm going to spend a few minutes talking about some of these disorders that are associated with the viable aneuploidies. We'll then move into talking about some of the clinical implications of transfer. And lastly, I just want to review what our genetic counseling services are, what we offer, what we talk about with your patients, so that you have a better understanding. So we'll start with trisomy 13, which is also known as Patau syndrome. It has an incidence of about 1 in 12,000 live births, and about 5% of cases are reported to be mosaic. Some common features can include central nervous system malformations, microphthalmia, and a cleft lip and/or palate. Trisomy 18, which is also known as Edwards syndrome, has an incidence of about 1 in 6,000 live births, and again, 5% of cases are mosaic. Common features for trisomy 18 can include intrauterine growth restriction, congenital heart disease, and micrognathia. Only about 5 to 10% of children with trisomy 13 and/or trisomy 18 survive their first year of life, and all are affected significantly with intellectual disability. Prenatal diagnostic testing, such as CVS or amniocentesis, is expected to identify these conditions, although in the non-mosaic form. And prenatal screening, such as ultrasound, may not identify these conditions. Trisomy 21, or Down syndrome, has an incidence of about 1 in 700 live births, and 2% of cases are mosaic. Some common features can include characteristic facial features, hypotonia or low muscle tone, intellectual disabilities, congenital heart defects, and duodenal atresia. And on the right is a picture of Lucas, who is the first Gerber baby with Down syndrome. It's important to note that the level of mosaicism can vary person to person and even tissue to tissue. And that's why mosaicism for any chromosome, there can be differences in presentation of symptoms even in two people who are mosaic for the same finding. Turner syndrome, also called 45X or even monosomy X, occurs in about 1 in 2,500 live births. About 30% of cases are reported to be mosaic, and I've listed here 3 examples of mosaicism that can occur with 45X. Some common features can include short stature, primary amenorrhea, an increased risk for congenital heart defects and renal anomalies, as well as the potential for learning disabilities. It is important to note that not all babies are recognized to have Turner syndrome in that infant or newborn period. In fact, some girls may not come to attention until later in adolescence or even into adulthood. In fact, individuals who are mosaic for Turner syndrome may present only with infertility. While 30% of cases are reported to be mosaic, it's theorized that potentially all cases of live births with Turner syndrome are mosaic, given the high rate of pregnancy loss that's associated with 45X. There's about a 98% loss rate. Other sex chromosome aneuploidies, such as trisomy X, Klinefelter syndrome, and 47XYY, are listed here. These sex chromosome aneuploidies tend to be on the more mild end of the spectrum, and in fact, men with Klinefelter syndrome may only come to attention as part of a workup for infertility. The incidence of mosaicism for these other sex chromosome aneuploidies is unknown. The last chromosomes I'm going to talk about are chromosomes 14 and 15 and their association with disorders of imprinting. Uniparental disomy, or UPD, occurs when both copies of a chromosome is inherited from the same parent, and there's no genetic contribution from the other parent. Disorders of imprinting result because genes are preferentially activated or silenced based on the parent of origin. UPD can occur as a result of a trisomy rescue event. On the left side of the picture, you'll see that there are 2 paternal copies of chromosome 15 and 1 maternal copy. If the maternal copy is lost, the result is paternal UPD for chromosome 15 and would result in Angelman syndrome. The reverse is true for the right side of the picture. In this case, there are 2 maternal copies of chromosome 15 and 1 paternal copy. If that paternal copy is lost, the resulting daughter cell would have maternal uniparental disomy, and that would cause Prader-Willi syndrome. Disorders of imprinting have been reported for both maternal and paternal UPD of chromosomes 14 and 15. I've listed the associated syndromes here. Of note, paternal UPD of chromosome 14 has a more significant phenotype than maternal UPD 14, but all are expected to be serious in nature. Now that we've reviewed the various syndromes that are associated with these known chromosome aneuploidies, I want to spend a little bit of time talking about the clinical impact of transferring a known mosaic in these select chromosomes. It is important to note that mosaicism has been reported for every chromosome. And when you're talking about mosaicism for the viable aneuploidies that we discussed previously, there is certainly a risk for having a live birth with features of that chromosome abnormality. So next I want to talk a little bit about reporting for these chromosomes that we've already mentioned. Mosaicism preferences can vary by both provider and clinic. We do provide the option for mosaicism to be reported or masked. Sheila did a nice job mentioning previously that when mosaicism reporting is desired, that our thresholds are between 20 and 80%. When mosaicism is masked, however, the reporting parameters are different. Greater than 40% abnormality is reported as aneuploid, while less than 40% is reported as euploid. However, the exception is when chromosomes 13, 14, 15, 18, 21, X, and Y are involved. Any abnormality greater than 20% involving the above chromosomes will be reported as aneuploid. So basically, when mosaicism is masked, any mosaicism detected to the clinical resolution of the test in these chromosomes will be called aneuploid. Another point to consider when thinking about the viable aneuploidies is complementary chromosome makeup. You can see here on this picture on the right that when there's an error in mitosis, one resulting daughter cell will have a trisomy, while the other resulting daughter cell will have a monosomy. This is particularly important if you see a monosomy on a trophectoderm biopsy. It may actually be indicative of a trisomy cell line and vice versa. Victor et al. In their 2019 paper set out to test this idea by taking additional biopsies from 5 embryos that were originally classified as mosaic. Reciprocal findings were observed in 3 out of the 5 samples, thus demonstrating the idea that complementary chromosome makeup does happen. I wanted to just take a minute to discuss this case study that was published in early 2020 about mosaicism that was detected in a live birth. So the patient was a 39-year-old female with diminished ovarian reserve who transferred an embryo with mosaic monosomy 2 that was observed in about 35% of the sample. She underwent amniocentesis at 17 weeks, which showed mosaic trisomy 2 in 2 out of 100 cells tested. The amnio findings were observed in 2 separate culture flasks, and FISH also confirmed the presence of mosaicism. There were no findings on ultrasound at 20 weeks gestation. The baby was born at 37 weeks with normal growth parameters and no observed abnormalities. A blood karyotype after delivery showed the presence of mosaic monosomy 2, again in about 2% of the sample that was tested. The placenta was not tested. This is the first case of mosaic monosomy 2 in a live birth after the transfer of a known mosaic embryo. And in this case, the presence of both monosomic and trisomic cell lines do illustrate the cause as a mitotic non-disjunction error. So now that we've reviewed the syndromes that are associated with the viable aneuploidies and a little bit about clinical impact, I want to talk to you about genetic counseling, and specifically our genetic counseling about mosaicism. If your patient has a PGTA post-test genetic counseling consult with Cooper Genomics, what's included? We do offer to review a 3-generation family history or just to discuss specific family history concerns in every consult. We also ask both patient and partner about carrier screening results as well as karyotypes in order to have the full picture and clinical information in the context of their PGTA results. The content of the post-test consult is largely patient-driven. We certainly have concepts that we want to review with every patient, which I'll detail on the next slide. But we do offer to review all results or just address specific patient concerns or questions. After the consult, a letter is generated and sent to the ordering provider, so you have a detailed record of what was discussed with your patient. We have some basic topics that are covered in every post-test consult. It is important for the patient to understand the difference between the trophectoderm biopsy and the inner cell mass. In the case of mosaicism, we discussed the possibility that the inner cell mass could be euploid, aneuploid, or mosaic, and that there is not a good way to test this in the embryo. The expected euploid-aneuploid rates based on maternal age are also discussed. When mosaicism is reported, we review that mosaicism is not related to maternal age, as it is due to a mitotic error, not a meiotic error. We spent some time discussing the accuracy of PGTA, as well as the fact that PGTA is a screening test and is not a diagnostic test. We also make recommendations for prenatal diagnostic testing, such as CVS or amniocentesis, as a way for patients to confirm their PGTA results. I tried to put together a list of topics that are typically discussed during a post-test genetic counseling consult, especially when there is a mosaic result. Results after transfer of mosaic embryos versus euploid embryos is a common question. Several studies have demonstrated higher rates of failed implantation and/or miscarriage in the mosaic group compared to those that are euploid, as well as lower rates of ongoing pregnancies and live births for mosaic embryos. Specifics related to the chromosome findings are discussed as well. For the live birth chromosomes, we discussed that the inner cell mass could be fully aneuploid and what that might mean for an ongoing pregnancy. For deletions and duplications, if they are part of a well-described genetic condition, the associated findings are reviewed. Anytime there is missing or extra chromosome material, there is a risk of physical and/or intellectual disabilities in a child. If the inner cell mass is mosaic, it is often difficult to predict outcome, as that is dependent upon the level of mosaicism as well as the tissues that are affected. When chromosomes 13, 18, 21, X, and Y are involved, we discuss the idea of complementary chromosomes. Since mosaicism arises from mitotic errors, the presence of a monosomy on a trophectoderm biopsy may indicate that there are trisomic cells present that were just not included in the sample. Possible UPD if chromosomes 14 or 15 are involved is also reviewed with the patient. Patients will often ask us to rank their mosaic embryos or tell them which ones they should transfer. This is not something that we as genetic counselors are able to do. So some conclusions from our presentation today. PGT-AI 2.0 is a robust platform. It's built on artificial intelligence and utilizes automated calling to remove subjectivity. It is also able to provide mosaicism detection between 20 and 80%. It is important to understand how the PGT lab you're utilizing reports mosaicism, how that mosaicism is reported or masked, and how those live birth chromosomes are handled as well. PGT-AI 2.0 mosaicism reporting follows the existing society guidelines that were outlined earlier by Sheila. And lastly, it's recommended that any patient who's considering the transfer of a mosaic embryo should have genetic counseling. To this last point, we are here to help. We know this is complex information, and if you don't talk about it every day, it may be challenging to provide the level of detail that patients are typically seeking. Feel free to contact our genetic counseling team with any questions that you may have or request that your patient is scheduled for a post-test genetic counseling appointment. Our last two slides include all of the references from our presentation today. Thank you for your time and attention as we reviewed mosaicism and genetic counseling at Cooper Genomics. We're here to answer any questions that you might have. Cooper Genomics. We're here